Hello, I'm Mort Kern. We're at the University of California, Irvine Cardiac Catheterization Laboratory, and I'm going to talk to you today briefly about fractional flow reserve, both the basics, practical aspects, and pitfalls, and then why we should use FFR for detection of ischemia and what our goals should be in the treatment of our PCI patients. Let's start with the basics, practice, and pitfalls. So we know that to measure FFR, we have to insert the pressure wire across a stenosis. There are 5 steps prior to getting to that point, which we will talk about briefly. We have to first connect the equipment correctly on the table. Second, 0 to atmosphere, both the guide catheter and the guide wire. Third, advance the guide wire into the guide, and at that point match pressures, not 0, but match pressures between guide and guide wire. Fourth step is to cross the stenosis. Fifth step is to give the adenosine and measure FFR. One extra step at the end would be to pull back and make sure we haven't had signal drift. And we'll talk about that at the end of this talk. So here's a cartoon of the pressure wire beyond the stenosis. Here's a display of the aortic pressure in red and the coronary pressure in green. At maximal hyperemia, in this case at the initiation of the hyperemic period, we can acquire our ratio of distal pressure to aortic pressure and produce our FFR number. We know that this number is an in-lab, artery-specific measurement of the ischemic potential, which is equal to what we would get if we did a stress test on this one artery. Now, to get an accurate FFR, we have to be aware of some of the pitfalls and problems that we're going to find out. So we have some technical aspects which we should attend to, some anatomic considerations, some mechanical and pharmacologic considerations, and hemodynamic artifacts. And I'll show you examples of all of these in the next few minutes. Make sure that your connections are tight, there's no loose connections anywhere, there are no bubbles, and of course we have to zero the guide and guide wire pressure properly. We may encounter difficulty with any guide wires in tortuous arteries, specific approaches to serial lesions, and sometimes we will not be able to get a guide wire everywhere we want to go. With regard to mechanical problems, make sure our guide catheter is not obstructed. We don't use side holes in guide catheters. We will make sure that we get adequate hyperemia, a subject of very great importance. And finally, for hemodynamic artifacts, we want to be cognizant of whenever we have a damped pressure waveform. This might be due to the guide catheter or contrast media in a small guide catheter, and we'll identify the ability to detect signal drift. And of course, I think side holes are unnecessary. If we have an ostium that is already damped, we will not be using a seated guide to make measurements. So here are the 5 steps that I just outlined briefly, and to get an accurate FFR. 1, zero the guide wire and table to wire on the table to atmosphere. 2, insert the wire into the guide and match pressures. 3, cross the lesion, and generally a couple of centimeters distal to the lesion is what we do. Turn on the adenosine, measure the FFR, and then confirm accuracy with pullback. Now, for zero and equilibration, it doesn't really make a difference where the sensor is relative to the guide, because pressure is the same in the aorta and all the way up the guide almost down to the leg. But in general, we like to we like to match aortic and guide catheter pressure in the central aortic position with the transducer close to the end of the guide. That's been the traditional teaching. We want the wire introducer removed from the wire connector. Here's the effects of having a wire introducer remaining inside the artery, inside the guide wire Y connector, and you see the little leak of blood produces a little loss of pressure. So here is with the guide wire introducer inside the guide catheter Y connector, and you can see this small amount of pressure difference created, and when we remove that wire introducer, the 2 pressures match again. There are different size pressure wire introducers. It's best to measure the pressures with that wire introducer out. We use intravenous and intracoronary adenosine to produce maximal hyperemia. That's these first 2 drugs. We don't use papaverine anymore, and we could, if necessary, When adenosine is not available or not possible to be used, use intracoronary nitroprusside. The doses are listed here. My preference is IV adenosine under all circumstances because we don't have to worry about guide catheter damping because we won't have the guide seated. We can do pullbacks and we can do osteal lesion assessment. So 140 mics per kilo per minute, peak time in 2 minutes, measure at 2.5 to 3 minutes, turn it off after that. Now, these are lesions best assessed by intravenous, that is left main, osteal, and pullback, plus any other lesion. And we can be sure that intravenous generally produces maximal hyperemia. Intracoronary has also, but it doesn't do the things that intravenous does. So if you're initiating a program, my recommendation and current teaching is to go with intravenous adenosine at all times. What about guide catheter damping? Well, we no longer use 8 and rarely use 7 French guide catheters. And that's good for FFR measurements because when we looked at the cross-sectional area occupied by an 8 French or 7 French guide catheter in a 3 millimeter vessel, we were occluding half the vessel diameter or more. You cannot get an accurate assessment of a lesion when you're halfway occluded across the ostium of the coronary. A 6 French occupies only about 30% of the ostium and rarely damps, but if it does, then we'll have to employ methods which ensure that we do not damp inflow into that artery. Here's a cartoon of a guide catheter, 7 French in a 3 millimeter vessel, and here's a damped pressure tracing. On engaging the guide, you can see that the guide catheter and guide wire pressure now are equal, producing an FFR of 1 when clearly the FFR is separated of less than 0.8. So this is the most common reason to get a false negative FFR when measuring the lesions. Here's another more subtle example of damping in the guide catheter. If you look here on the top, you see a large aortic pressure with a funny terminal portion, at least in this beat. The pressure wave in yellow beyond the coronary stenosis is big. The FFR calculated with a slightly damped aortic pressure is 0.81. When we remove the guide back and we produce less of a damped tracing, our FFR now is accurate and true and significant. So caution all the time toward aortic pressure damping should be made. That's why you have to look at the tracings to get an accurate number. We don't use side holes because they create a pseudostenosis. Blood has to go in the hole, through the catheter, and into the artery, and so you have a stenosis created by the side hole. It's important to remember that the sensor on the guide wire may be subject to contact with the vessel wall if it's in a tortuous or highly calcified vessel. And this is the source of some artifact for pressure measurements. Here's an example of the wire impacting on the vessel wall, producing catheter whip. So the sensor hits the vessel wall and produces this artificial abnormal signal. Likewise, this was an example of a transducer contacting a calcified plaque, and it produced complete artifact and disintegration of the signal. And when moving the transducer off that calcified plaque, we got a good signal portion as shown here on the left. Respiratory variation also can produce some consternation with regard to what the accurate FFR is. It's best to measure FFR with relatively suspended respiration, although the ratio of these numbers varies little bit. In this case, the FFR remained normal over the respiratory cycle, but in some individuals with big respiratory cycles, it can be abnormal. The influence of a single ectopic beat produces a change in pressures, obviously, and we're not going to record the FFR during this ectopic beat. It'll be the same before and relatively the same afterward. So this is not an issue. Now, the onset of adenosine is starting up over there, I believe. At the conclusion of our measurements, we want to pull the guide wire back so that it matches aortic pressure. So here's a pullback of pressure from the coronary wire, but it never matches the aortic pressure. So there is some signal drift in this particular example. Whereas when we do an accurate pullback with no signal drift, as we move the pressure back across the artery, and across the lesion, the signals now match up, and we know that this was an accurate depiction of the FFR at that point. When we talk about signal drift, we know that the dicrotic notch of distal pressure from the aortic pressure should be blunted. Whenever you have your aortic dicrotic notch and you see it beyond a stenosis, you have to wonder, is this difference true or not? This is actually an example of signal drift where the two pressures, aortic and coronary pressures, matched identically, and when we crossed the lesion, they were persistently identical in shape. This is not a true stenosis. A true stenosis produces a loss of the dicrotic notch, and the more severe the stenosis, both systolic and diastolic pressure differences are pronounced. This is the pattern of a true stenosis, not this pattern with a persistent dicrotic notch. We're talking about causes of false negative and false positive fractional flow reserve measurements. Let's look at false negatives first. The two most common causes of producing a false negative FFR are pressure damping of the guide catheter, and second, lack of hyperemic response. This would be due to either the wrong drug, the wrong mixing, or the wrong delivery. Side holes was a consideration, but all of these things produce questions about our hyperemia. With regard to false positive FFRs, if you have a small territory and a small artery, despite having a significant stenosis, you could have a significant FFR or even an insignificant FFR. And pressure signal drift may produce a positive FFR. We've talked about the basics of FFR, the setup, sources of artifact, problems with equilibration, signal drift, and other reasons to have false positive and false negative FFRs. Let's talk for just a minute when we apply that information to a case like this. Here's a stenosis. In the circumflex ostium, we really would like to know whether this is important or not. We measure FFR. The number comes back at 0.89, a normal number. Let's confirm what we know. We checked the zero and equilibration. It was accurate. We achieved maximal hyperemia with IV adenosine. We had our guide catheter not damped. We looked at the signal while we were recording. We did a pullback of the wire back into the guide. We saw no signal drift. We did it twice. And now we have the same result. So this is an accurate FFR. And for all the reasons we know why the angiogram fails us, the FFR does not.